Welcome back to the podcast on non-interpretive skills in radiology. Today we're continuing the conversation about core safety in radiology. My name is Nadia Kedem and I'm joined by Lyle Saar, a medical student.
All right. Then let's talk a little bit about human error and safety culture and just culture. So for human error, there is a concept that's called the skill rule knowledge concept, SRK. It's
Yep.
something that I've never fully understood and that I don't fully agree with. So I'm just going to give a few pointers and then we can move on from that. Skill-based actions are the ones that require little conscious attention, just like driving a car or a bicycle, something that you tying your shoelace or something like that. When you make an error for those, they typically are best addressed by just teaching you how to do it better. It's mostly lapses that happen in those kinds of actions. The rule-based actions is when you have to make a decision, and the knowledge-based actions are actions that require a high degree of concentration. So if you have to decide whether it's safe to scan a patient with a foreign body, so that could be a rule-based action, or something that requires a lot of concentration is maybe when you have to read a complicated neck cancer CT scan where you could easily miss something and the anatomy is very complicated. When there are errors in those areas, they are mostly can be improved through training and coaching and intelligent decision support. But I don't like this concept and we're gonna just move on. Talk about a culture of safety.
Yes.
So safety culture is actually something that comes from leadership. Culture is always top down. So your leadership sets the culture. Our leaders politically, personally, professionally, they set the culture. So they are responsible in some ways on how we follow their role modeling. So that it's really important. And a lot of leaders don't recognize that. So it's important that they acknowledge that healthcare is a high risk system. They have to make sure that we're not blaming people and role model that kind of behavior. They have to go around and talk to people at all sites and departments and modalities, the frontline workers, the managers, the faculty, everybody. Encourage collaboration. And they have to also commit to invest in the resources that we need. So, for example, all these reporting systems for error that cost money, and you have to hire people to manage those. So you can't have a safety culture without also paying some money into it and putting all of this infrastructure in place.
Yes.
One important concept in a safety culture is this authority gradient. What do you know about authority gradients?
I think in healthcare, at least, we have the technologists, we have medical students, we have nurses, we have doctors, and then we have administrative CEOs. The steeper this gradient between each level, there's more barriers to the people who are on the lower gradient level to be able to freely speak up or to have a say in what they observed or they want to report. It says here that such authority gradients not only undermine the safety culture, but increase the difficulty of accurately measuring these error rates. So,
Yeah, that's very true. And you've been in the operating room, so traditionally that's a very authoritarian kind of structure, right? The surgeon controls everything. When they yell out they need something, you have to hand it to them right away. And it can be very intimidating. It's a very high stress environment. I do understand why surgeons are the way that they are, but it does create a barrier where people who have a concern in the room, like a nurse, or maybe if you're a student standing by and you see something that has you concerned, you don't want to speak up. So maybe you do notice or you do think that we're about to amputate the wrong leg, but you're afraid to say it because they are thinking, I'm just a medical student and there's like all these professionals here. They've done this before. They must know what they're doing. And if I speak up, I get yelled at and I get a bad evaluation. So you don't say anything. This is very critical. And it was discovered actually in the airline industry, which is also a high reliability organization. And the airline industry has found some airplane crashes that could have been avoided because the flight attendant noticed something, but they didn't want to speak up to the captain of the airplane because of that authority gradient. So there are systems in place now. They have team trainings, and it's absolutely understood that anybody with a safety concern needs to be able to speak up. So it's a more collegial environment that invites feedback. Any concern should be voiced. Even if you're wrong, that's fine, but at least everybody can check on it and then make sure that they're on the right path. So that's very important. Yeah. It's important always when you want to achieve improvement to have data. So sometimes people promote measuring the culture of safety. There are actually some measurement tools out there. ARC has a survey, and there's a safety attitudes questionnaire that can be used for measuring. So measuring safety culture is possible and should be done so that you can see if you're improving on that.
Yeah.
And then the big component of safety culture is just culture. What do you know about just culture?
The key word that pops up into my mind is what we actually discussed in the beginning of this is emphasizing accountability rather than blame. So I think that kind of is where it started. It was started by David Marks. He was responsible for a lot of other things, but this is one of them. And it tries to distinguish between human error, at-risk behavior, and reckless behavior. Those are the three things that I think it really tries to distinguish. So I think
Yeah,
that's
this is perfect. And these three types of behaviors are the key in a just culture, like you said, to balance accountability with blame-free culture. For human error, what is that?
when somebody unintentionally, I think that's a big factor of human error, is without intent, mistakenly forgets to report some, or forgets to look at something, or forgets to record a measurement without any malice or ill intent.
So it's usually no intent and also usually no awareness that something is going wrong. For example, when you click the wrong item on a drop-down menu, you think you're clicking on the right thing, but your mouse moves by a millimeter and you accidentally click the wrong thing. So that is a human error, unavoidable. Our reaction should be just accepted. And if there's an error that harmed the patient, that was just one of these lapses or human errors, then probably the person who made the error feels terrible. So we should console them if they're suffering from this. And that's very different from the old way of handling it, where there would be anger and blame for just a human error. So that's completely unjustified. Then there's at-risk behavior. How is that different from human error?
At-risk behavior, the example they give is like taking shortcuts. I guess in radiology, when we're reading things, reading or trying to generate reports using copy and paste functions, thinking that it's accurate enough, or when people write notes in general, when they copy over things. So it's not inherently malicious, but it's trying to save time, take shortcuts. There's no active awareness that it'll lead to harm. I think that's a big distinguishing factor between reckless behavior. So,
Yeah, so to be clear with the awareness, so there is awareness because you make a conscious decision to copy paste the history from another letter into your letter, but there is a belief that it will not harm the patient or that it's justified because it saves you time and you really need to write 10 more letters tonight. So that's the difference. Yeah, so there is some awareness and there is just not a believed risk. Those kinds of behaviors need to be coached when they lead to an error. You have to make clear to people that they can't copy paste or not without checking exactly what kind of content they're copy pasting. And if this happens repeatedly on the same issue and you need coaching repeatedly, that could actually become a performance issue. But if it happens once or twice, it's not an issue. And then there's also the idea of a substitution test. If all the physicians in your team do this copy pasting, right? It's not just one person, but everybody does it. Then you have to wonder, is there something wrong with our system that everybody feels the need to do that? So why Do we have to rewrite these letters when there's information that's already available? Can this be handled smarter with the technology we have available to save that time? So there might be other ways, but this is interesting to look for the substitution test. Would others with a similar job do the same thing? And then if they do, then you probably have a system issue at your fingertips and not a personal performance issue. And then there's reckless behavior where there is intent and awareness that there will be harm. So those are people who purposefully harm patients or people who are coming to work maybe intoxicated or under the influence of drugs, which is irresponsible behavior. So those would be examples of reckless behavior. That happens extremely rarely. Most of the time, we're dealing with human error and at-risk behavior. So we're having consoling and coaching. Talking about consoling, there is this concept of the victims when an error has happened. So there's actually 3 victims. Do you know who the 3 victims are?
I think it's the patient. So
Yeah, that's the first victim.
I know that there's a second victim,
Yes.
but
Okay. The second victim is the provider who made the mistake. If the mistake harmed the patient, that provider might feel terrible. You can imagine if you gave the wrong medication and the patient dies or has a stroke or something like that, you feel terrible as the provider. And it could just have been a human error, something you were unaware of, and it was completely unintentional. That's the second victim. And then the third victim, a lot of people don't know about this, but the healthcare practice or the provider or the organization is the third victim for many reasons. Number one, if word gets out that this error happened, they suffer in their reputation. Patients may not return for service. But also, if you treat the provider unfairly who made the error, then they might leave, and they could be really great providers with a lot of knowledge, institutional knowledge and experience. And now you lost that expertise in your organization. You have to hire someone new. You have to onboard them. It's actually quite costly. So that's another way where the organization can suffer. So, yeah. Okay. I think those are the fundamental elements of a just culture. I encourage everybody to read more about it. It's a really fascinating topic. And you know so much about it, Lyle. You're fantastic. Thank you. Okay, that's it for today. Thank you very much.